So moving on to our last talk for this session, New Kid on the Block by Dr. S. Kavita. Dr. Kavita heads the glaucoma department at Arvind Eye Hospital, Pondicherry. She graduated from Tanjavur Medical College and did her master's from Arvind Eye Hospital, Madurai. She is actively involved in training of residents and fellows. She is one of the key investigators in the landmark iFace trial conducted at Arvind in collaboration with the Wilmer Eye Institute. She has won the Best Paper, Poster, and Video awards from various ophthalmic societies, including the Tamil Nadu Ophthalmic Society, AIOS, and GSI. So, welcome and over to you, Dr. Kavita.
Thank you, Dr. Sharuba, for the kind introduction. So, let's proceed with the talk. My topic for today is the newer kid on the block, the ROCK inhibitors. I do not have any financial interest in the subject matter of presentation. So why do we need to have a new drug? As we all know, and as we have been discussing for the past more than 1 hour, we know the one and only modifiable risk factor in the management of glaucoma is the control of intraocular pressure. And the primary method or the first line of management to achieve this in most of the patients is with the medical therapy. Though we have alternate line of treatment like neuroprotection and the newer drugs and the newer drug delivery system are coming into practice like or still on the research side, and nothing has come to daily practice. And actually in the literature, if we look at after the pilocarpine, we don't have any drug which acts on the conventional outflow pathway, which is actually responsible for 75% of the aqueous resistance and which is responsible for causing glaucoma. So this shows the timeline of the various glaucoma medications. We can see after the introduction of prostaglandin analogs, almost for past 20 years, we don't have any new medications coming into the practice. So that's how this rho kinase inhibitor evolved, and these rho kinase are small G proteins, and they get activated by binding to guanosine triphosphatase, exert their action through actin and actomycin assembly, and the results will be the cellular contraction, cell adhesion, and ECM organization. So these rho kinase inhibitors, they inhibit the rho kinase isoforms which are present in the trabecular meshwork. It alters the cytoskeleton of the trabecular meshwork and the Schwann scan, reduces the resistance to the aqueous outflow, and that reduces the intraocular pressure. This is showing a various mechanism of actions of this rho kinase inhibitors. Apart from reducing the intraocular pressure, there are another few ways. So, it prevents the transdifferentiation of the myofibroblast from the Tenon's fibroblast, which is responsible for subconjunctival scarring, which is the main mechanism for the trabeculectomy failure. And this drug is helpful in preventing the scarring. Also, because of its properties on the blood vessels, vasodilative properties, it increases the blood flow to the retinal ganglion cells, and also it prevents apoptosis, and hence it is supposed to have neuroprotective effects. So this shows the various ROCK inhibitors in the market, either in the research side or a few of the drugs like ripasidil and etasidil are now available in India also. Fasidil has been there for quite long time. Used as a vasodilator in patients with stroke for the cerebral vasospasm. And the first ROCK inhibitor to receive the marketing authorization is ripasidil, which is for glaucoma and ocular hypertension, approved in 2014, and it is used as a 0.4% formulation in a twice daily preparation. Kanihara et al. Did a study to assess the various formulations of ripasidil and compared it with the placebo. 0.2% and 0.4% were compared with the placebo in patients with POAG and ocular hypertension. And ripasidil, especially 0.4%, evolved as a promising new topical medication to lower the intraocular pressure at least for 7 hours in these patients with POAG and ocular hypertension. So this figure shows intraocular pressure reduction 2 hours after the first installation and 2 hours after the second installation, which is 6.4 and 7.3 respectively. Again, this is the results of post-marketing surveillance study, again by Tanihara et al. And this is a 2-year surveillance study, and the 3 months interim results are out, and the 2-year surveillance study got over only in 2020. We need to wait for the results. In this study, they analyzed the intraocular pressure control and the adverse drug reactions in the first 3 months in 3,058 patients. 8% of them developed adverse drug reaction in the first 3 months, and the most commonest being, as discussed by the previous speakers, it is conjunctival hyperemia. And mean intraocular pressure change was 2.6 plus or minus 4.1 millimeters of mercury. However, we need to wait for long-term results. In this ROCJ trial, there were various other things were evaluated. This figure shows the evaluation in different types of glaucoma. So we can see a significant reduction in the intraocular pressure from baseline in almost all the types of glaucoma. And this is regarding the various range of intraocular pressure. We can see here again, there was a significant reduction from baseline. However, we can see here the maximum pressure reduction was with those who had a higher baseline intraocular pressure, which happens with any other drug. And also they evaluated in different forms of secondary glaucomas. It was effective in exfoliation glaucoma, uveitic glaucoma, and also steroid-induced glaucoma, though the numbers were not too high. But it was not effective in neovascular glaucoma. As we know, the pathology is different here. And also it was evaluated in 5 different groups of patients, either as an initial monotherapy or initial combination therapy or switchover therapy from previous treatment as add-on only drug or add-on drug with other anti-glaucoma medications. Again, it was proven to be effective in all the 5 groups. So it was also tested as a fixed combination with timolol and latanoprost, and with timolol, it was effective as a combination both during the peak and during the trough, but with latanoprost, it was effective only during the peak. Coming to the adverse drug reactions, the most commonest is the conjunctival hyperemia, and it is very important to educate the patient because of this possible side effects. Otherwise, most of these patients will discontinue the drug because of this particular side effect. The other possible side effects include blepharitis, allergic conjunctivitis, and punctate keratitis. As glaucoma consultants, we are also very much worried about the corneal endothelium. So because raised intraocular pressure as such can damage the corneal endothelial cells, and some drugs can be even cytotoxic to these endothelial cells. And even after following a glaucoma surgery or a cataract surgery also, there can be an endothelial compromise. And this new drug, this RAC inhibitors have shown promising results in animal models. When combined injection of this endothelial cell culture along with the ROCK inhibitors are given as intracameral injection, and these drug was now found to increase the cellular proliferation and cell addition, which seems to be promising in conditions such as fugues or acute corneal injury following a trauma or intraocular surgery. It is also showing some promising results again in the animal models following initial stages of diabetic retinopathy. If given as repeated intravitreal injections, it is supposed to prevent progression to the severe form of diseases such as proliferative diabetic retinopathy. However, we need to wait for long-term results. Next in line is netarsidil. It is approved in USA as a 0.02% formulation as in the name of Ropresa. In India also we have these drugs available in the form of Netalo and Reiki. However, these are relatively new drugs, and this the one unique thing about this drug is the triple action drug. Apart from being a rho kinase inhibitor and increasing the conventional outflow as discussed earlier with Repasodil, this is a norepinephrine transport inhibitor, and thereby it reduces the aqueous production. Also, it reduces the episcleral venous pressure. So it has got 3 mechanisms by which it takes care of the intraocular pressure. Bracket 1 and 2 trials evaluated netarsidil and compared with timolol, where it was proven to be non-inferior to timolol only in patients whose intraocular pressure, presenting pressures were less than 25 millimeters of mercury. However, this drug was not found to be non-inferior to latanoprost. So in this bracket trials, even the fixed combination, the twice daily dosage and once daily dosage were compared with the timolol, Both the dosages, though they were non-inferior to timolol, when we increased the dosage to twice daily, the adverse reactions increased. Also, after the trial, and this was found to be as can be recommended as a first-line therapy in patients with normal tension glaucoma. Coming to the adverse drug reactions, again, conjunctival hyperemia is very common as with ripacidil, and as shown by Dr. Gauri, the small petechial microhemorrhages in the conjunctiva and the cornea are common, and these are actually reversible while stopping the drug. And cornea verticillata, as shown here, though this looks like really scary, this does not interfere with and this also self-resolving on cessation of the drug. The other effects include installation site pain, erythema, blurred vision, and increased lacrimation. So fixed combination has also been approved in US in the name of Rocklatan, and this fixed combination Rocklatan of netarcidil and latanoprost has proven to be very effective as compared to either monotherapy with netarcidil or with latanoprost. So the potential drawbacks of netarcidil include it may not be effective in glaucoma. They are potent vasodilators, can cause hyperemia and subconjunctival hemorrhages. And because of this dilatation, there is a danger of greater systemic absorption of the concomitantly administered drugs, and it might also decrease the ocular potency. And it might be worsening the uveitis, although it is not yet reported. So where do we keep these ROCK inhibitors? We need till date also, the prostaglandin analogs gives the maximum pressure reduction and will continue to be the first line of drug. And to summarize, ripacidil 0.4% twice daily preparation increases the trabecular outflow. It is neuroprotective and improves the ocular blood flow and prevents conjunctival scarring, especially post-glaucoma surgery. Netarcidil is a triple action drug, and the adverse reaction include corneal conjunctival hyperemia, subconjunctival petechial hemorrhages, and cornea verticillata. To conclude, these drugs can be used as a first-line agents in normal tension glaucoma, and they might be effective in certain forms of glaucoma where the pathology lies in the outflow like steroid-induced glaucoma. It can be effective as a combination therapy with prostaglandin analog, has a good role as an adjuvant therapy, as an add-on therapy when we want to postpone a surgical intervention, and it has protective effect on the corneal endothelium, and it inhibits the fibroblasts and prevents subconjunctival scarring. So when to prescribe? So conditions in which timolol is contraindicated, as discussed very well by my previous speakers, and conditions where prostaglandin analogs are contraindicated like inflammatory conditions or allergic reaction. It's valuable in patients as an add-on therapy, and in patients who have associated corneal pathology or a post-corneal grafting, this is very helpful, and we can prefer ripacidil in case if we want to start an anti-glaucoma medication post-incisional surgery. Thank you. Thanks for the opportunity, Dr. Sushma and the AIOC. Thank you.